Hey guys, good morning. This is Dr. Wong from PhysioU, and I'm excited to take a few moments to talk about some knee meniscal and ligament test injuries. And thanks to Dr. Minkin for inviting me to share a little bit with you. So we're going to spend a little time looking through the apps, PhysioU apps, and also to develop a picture of how these patients present, the mechanism of injury, the type of testing we might do, the treatment categories we might put the patient in, so that you have a good picture of how to examine and treat, as well as the patient profile, the clinical pattern related to these common conditions. So you can see that all of this content is tied directly to our apps and directly to the clinical practice guidelines. So what I want you to see here is when we talk about meniscal and articular cartilage lesions, the guidelines calls this knee pain and mobility impairments, because oftentimes when people have mobility deficits related to meniscal injury, it can be related to locking or loss of full range of motion. The primary impairment that we're going to be wanting to manage is to restore that range of motion. So that's the primary key finding. So what I want you to see here is that, and you guys will all get this in your imaging class, that these meniscus, these nice little triangles, you see how they are all nice and dark and intact. But in the case of the tear, you can see this white line through here. This has an indication of a tear, all right? And one of the key things I also want you to think about is many of these patients are going to come in and they're going to tell you about locking, clicking. And what I mean by locking is sometimes they can't fully bend or fully extend the knee. And so our job then is to identify that as, oh, that sounds like a mobility deficit. Let me see if I can restore that mobility. Right? Now, there are other impairments, of course, but the key impairment here is, as the guidelines notes, knee pain with mobility impairments. Okay, so you can have all kinds of different tears. Okay, here's horizontal tear, radial tear, an oblique tear. And each of these may have varying levels of ability to heal, right? So when you go back into the, let's go and visit the app just for a second. So we'll click into the app. And we are going to go into the knee joint. Now remember, you can always play through this via pain patterns. So let's talk about medial knee pain and think a little bit about what hypotheses might cause medial knee pain. And you can see that there are a number of different hypotheses that might do that, right? So you know that pain presentations aren't really a good predictor of what pathology is present. There are a lot of problems that could be present. But let's look at medial meniscal tear here. You can see that the prevalence data, which I've put into a table for you, we can look at it here. It's easier to read here, that the articular cartilage pathologies are reported in between 60 to 70%, okay, of knee pain patients. So that's prevalence. And 32 to 58% of it are a result of traumatic non-contact mechanisms. Okay, so some of them for sure, there can be traumatic contact, but many are the patient is just running, cutting, plant and twist type injuries, and boom, you've torn your meniscus. Now there's also some data about military personnel that you can look at. Here you see 8.2 meniscus tears per 100 athletes in professional basketball players, right? A lot of cutting and twisting, planted cutting and twisting. 23% of total high school athlete injuries involve the meniscus. Girls had a higher rate than boys. And lateral meniscus tears are more likely in younger athletes, medial tears more likely in older athletes. Okay, so if we go back here, So if we look at the clinical findings, let's take a look at how this patient presents. So this is in the clinical findings app, part of the app.
Knee pain and mobility deficits, or meniscal and articular cartilage lesions. The patient often complains of joint line pain, typically medial pain if the medial meniscus is damaged, or lateral pain if the lateral meniscus is damaged. During movements of the knee, the patient may complain of clicking or locking, after which the patient may have to manually unlock the knee. The patient may also report that location of the pain may change during functional movements, and motions of bending and twisting are provocative.
Right, because that's typically the mechanism of injury, right? The loaded meniscus and the twist. So remember what I want you to think about. If you think about hip labral tears, right, this type of cartilage injury, patients often complain of clicking. So meniscal injuries, similar, clicking and locking. All right. Now, again, let me just point you to the PowerPoint real quick. If you look at the PowerPoint here, there is a table that has the summary of what we're looking at from the app. So in the prevalence, here is your summary of the prevalence. And now we're looking at the clinical findings. What are the things that the patients tell you, the history, and what are the signs and symptoms? Okay, so all of that is summarized for you. Let me take you back here. If you look at the history, what are patients telling you about? Well, plant and twist trauma during sporting activity, right? I've loaded the meniscus, I'm twisting on it, and now I have torn part of my meniscus. It's also possible that hyperflexion or hyperextension trauma can lead to meniscal damage. There's also the possibility of insidious onset of meniscal injury. So it's not uncommon for us to have age-appropriate degenerative changes. So remember the non-traumatic insidious onset type meniscal injuries, they also may have clicking. They also may have locking. And yet there was no trauma. So there may be some possibility, there is some possibility of meniscal injury over time as we age. And remember, depending on where the meniscal tear is, medial pain, medial joint line pain for medial meniscus, lateral joint line pain for lateral meniscus, and potentially posterior knee pain. Okay, it just depends on where your tear is at. It's not always that easy to localize for a patient. And it can move. Sometimes it can move while the patient is going through functional movements. And the things that they tell you, joint locking, inability to fully bend or straighten the knee, clicking, swelling in the knee, these are all things that you should be listening for in the subjective exam. And when you go about your exam, we're often looking for palpating joint line tenderness, looking for guarding, clicking, pain with hyperflexion or hyperextension, and then primarily your Thessaly test or your McMurray test. Okay, so let me take you back here for a second to look at the PowerPoint. Here are your symptoms and your signs we just went through. I'm going to point you to the app in just 1 second. I just want to make the big picture here. If you think about the treatment-based classification, what do I do for people who have mobility deficits? Okay, well, in the acute phase, if they are highly painful and swollen, very irritable, we just need to do pain control. So you can do a number of your different modalities. You can immobilize the joint temporarily, right? So whenever someone is painful and swollen, it trumps all, right? It trumps any of your other treatment categories because you have to manage that pain and swelling first. And then they have mobility deficits. They don't have the ability to fully straighten or bend their knee. I need to restore that. And so that's why it fits nicely in this mobilization treatment category. Remember, eventually we want to exercise, restore range of motion, that give them exercises that help with mobility. And then eventually we need to manage the other impairments, which are strength, movement coordination, right? Teach them how to move. If they adduct and internally rotate at the femur all the time, we need to address those movement faults. Okay, so let's just take a second here, look in the app to see how all of that plays out. So if I go back here to medial or lateral meniscus tear, I look at the physical exam. Here under key findings, right, the things that are most relevant for this particular condition, I want you to remember that you can watch the key findings clinical reasoning video. It gives you a quick summary. If the patient is highly painful, we put this here so that you would think, oh, pain and inflammation is a top priority. I need to help manage that first before I start doing all of my crazy testing. If the patient's highly painful and swollen, it's very hard to do a lot of testing. Okay, so you might consider unloading the tissue, doing irritable knee positioning and oscillations, put them in an open pack and just help them ease the pain. Okay, that's the right thing to do. And the other thing that I would mention here, it's one of my favorite little, let's go back here. Oops. I'm going to go back to the clinical pattern recognition orthopedic app. I'm going to choose the knee. And under any body region, so we're in the knee, you can see that there's this rehab progression pyramid. This pyramid gives you a sense of priorities related to how do I manage impairments? How do I prioritize and manage impairments? So like I mentioned, if the patient is pain dominant or acute and inflammatory, then the management should be focused on managing pain and inflammation. It's the base of the pyramid. You can't get to mobing and stretching or strengthening or balance and gait or high level movement until you've taken care of the things at the base of the pyramid. So when we talked about unloading and icing and using modalities, this is to manage this basic problem at the base of the pyramid. Once that's taken care of, you actually want to move up into putting the joint in optimal posture because we think that minimizes stress on tissues. And then managing the mobility loss. So we always, once there's no more pain and inflammation, I can now restore mobility, restore muscle length and range of motion. Okay, we work on sensory and reflex integrity, work on now muscle performance, motor function, right, muscle strength. And once I've checked these boxes off, right, no pain and inflammation, full range of motion, good strength, I can start doing more complex things like balance and gait, or synergies, functional movements, skill, power, all of these things at the top of the pyramid. The last thing I would say is this pyramid essentially identifies the most post-op protocols follow this same pathway of management. Okay, so let's go back to the patient. Let's go to all diagnosis as a quick access to medial and lateral meniscus tear. And you can now take a quick look at the key findings here. Should I be assessing knee mobility? Yeah, absolutely. So you'll be learning in lab how I can assess active range and overpressures, passive range with overpressures, and look at tibiofemoral accessory mobility. This patient clearly has mobility deficits. They're locking, they're clicking, and so my primary key finding is to assess range. Now we can also look at, go back here, we can also do our meniscal assessment. And so here's your Thessaly test, your McMurray's test, your joint line tenderness. So if you let's just take a look at one of these tests here. So here you have the Thessaly test. You guys probably have watched this video. It's part of your lab already. You note that
with the patient standing, have them place their hands on your shoulder. You help stabilize their pelvis. Have them stand on one leg and flex their involved knee to about 20 degrees. Then rotate the knee as far as you can, each direction through the pelvis, looking for a reproduction of symptoms on the medial or lateral joint line.
Notice how this exactly mimics the mechanism of injury. Okay, so when you finish taking a look at the test, your key findings really are related to assessing mobility and then ruling in, ruling out whether you think the meniscal tissue is injured, right? Because the provocative tests like Thessaly's will help you get a sense, what am I dealing with and how well will this patient heal, right? Meniscal tissue is not typically well vascularized. It does not typically heal very well. Let me just mention the other things that are here. Remember, the patient has potentially medial knee pain from medial meniscus. So you can always rule in or rule out other joints. I think it's valuable. Remember, the patient could have just gone through a trauma. So you can rule in or rule out other joints by doing quick screens. These are just quick techniques that you can use, right, to rule in or rule out other joints. And we can also screen out other post-trauma structures, right? Because commonly the meniscus is injured with ligaments. And so here are some of your Patellar assessment, Mcl assessment, LCL, ACL. So these are other ways to expand your thinking. The patient comes in, has medial knee pain. I still need to differential out other structures, right? And we'll look at some of these other tests later, okay, when we talk about the other patterns. So I just wanted to put that there. That's what the differential tab is for, is to rule out other post-traumatic structures, rule out other joint line region structures, right? So what are some other things in that area that I want to rule out, whether it's medial or lateral knee pain, depending on which meniscus we think is injured, okay? If you look at movement faults, what we've put here is one of the common movement faults related to lower extremity injury. So it's always important to think about not just what is the traumatized tissue, but eventually if the patient presents with faulty movements that might predispose them to injury, I would want to observe for it during functional movement. Here's squat, here's single limb stance, here's step down, and to see if I can train them to correct that, right? Or address the impairments that might be causing it, all right? So you can investigate that a little bit further. And let's see, here's associated impairments. What are some other things that might be present that need to be managed? Edema and swelling, lower quarter muscle weakness, decreased hip muscle length, right? So a lot of tight muscles. It is also advised that we look at some isometric strength, okay? Isokinetic strength, sorry, and isometric hand dynamometry strength testing. So you get some solid numbers for quantifying strength loss. And let's see. We have some functional measures that you can always consider doing that a patient might demonstrate impairments in. So you can actually demonstrate improvements in activity limitation and participation over time during your rehab. So that's what all of these different categories are for. All right, let's go in lastly to look at interventions. Here are, again, a clinical reasoning video for you guys to watch. I think in the big picture, what you're looking to do, and let me take you back to the PowerPoint just for a sec. What we are looking to do is I need to reduce pain and inflammation, restore range of motion, use exercises to help restore range of motion, and then followed by moving up the pyramid, I need to restore the other impairments, strength, balance, proprioception, correct movement impairments, right? So that you can see that even though there are many categories here, this is primarily a mobility impairment category. So mobilization is right up here near the top. So if I go back to here, from a manual therapy perspective, right, I may choose to restore mobility. So all of these techniques that you're going to learn in lab, anterior glides, tibial femoral extension with overpressures, all of these different techniques are to address that primary key impairment. But you can also see that if needed, under the modality section, that cryotherapy, bracing, taping, NMES, these are all reasonable interventions to do. And you can see that there are grades of evidence coming from the guidelines. Okay, so meniscal and chondral injuries, neuromuscular electrical stim can be used following ACL reconstruction and meniscal or chondral injuries to increase quadriceps muscle strength. So this becomes something important for you to do. And you can always link back to within the app. Here is your Physical Agents app. And under neuromuscular electrical stimulation, you have your NMES for quads. All right, I forgot how to set it up. Well, there's a setup video. There's me doing a setup video for doing quad stim. The steps for setup, the parameters. Okay, all the evidence down here. Okay, so, and then remember, this is a mobility deficit. So the primary thing that we're managing is restoring mobility. So I'm back to knee, all diagnosis, medial meniscal tear, interventions, and eventually we go into therapeutic exercises where we talk about things that you would do to restore mobility. Here are your common therapeutic exercises. Here are some common things you would do to manage the weakness at the hips or manage the shortness of the muscles at the hips. Okay, this is under mobility, of course. When you move into motor coordination, here is gluteal strengthening, quad strengthening, correcting the movement fault. Okay. And if we look at functional movements, again, we can give them things that will help protect their knee in the beginning or different activities that will help prevent their movement fault of femoral internal rotation adduction. Last couple of things I want to show you here is patient education. The patient education here is to help you express to the patient and answer the 4 big questions that they always have in their mind. What's going on? How long will it take? What we are going to do during their care and what they can do to help themselves. Okay, avoid squatting and twisting, right? Avoid activities that make the pain worse. So this is your patient education. And because of our partnership with JOSPT, the journal, you have a link to all their common patient perspectives. So for example, the patient asks you, why are you doing hip exercises? It's my knee that's the problem. Well, there's a patient education article here. Knee pain, strengthen my hips, but it's my knees that hurt. So there's a link to references that you can use to extend your window of care. Give patients things to read and study about. So you can share this page with your patients just by clicking on this link. Now remember, I'm not going to go through this for all the conditions, but for each condition, there's an outcome measures here. Here are the common outcome measures. Here's the LEFS that you would use with your patients to objectively measure their disability. Okay, so you're going to want to look at these and know which ones that you want to use as a way to assess their disability at intake and then track their progress over time. So you have a number of these here. Okay. All right, so that is the end of meniscal injury. Lateral meniscus or medial meniscus, we lump them all together because they present with a common impairment, which is mobility deficits, mobility impairments. So we end up treating them the same. Okay, you put them in the same treatment category, mobilization. All right, so I'm going to keep going. You guys make sure you take a quick break. You can always pause the video whenever you need to take a quick break. And we are going to move on to the next category. And that's a little walkthrough of the app and how to organize your thoughts and recognize the patient related to meniscal injury. Okay, so for the next condition or the next set of conditions, we're going to talk primarily about knee ligament sprains. So you see in the clinical practice guidelines, and this was revised in 2017, that they have noted the ICF category as knee stability and movement coordination impairments. And the concept behind that is when these ligaments are impaired, right, or injured, that there is stability issues, right, buckling, patients don't feel comfortable cutting, and the movement coordination impairment implies that because these passive restraints are now injured, lax, torn, that the joint has a hard time staying near the middle, staying near neutral, which is why when you try to cut, your knee wants to buckle because you don't have the anchors. So the rehab concept for management is usually, how do I stabilize the knee near neutral, near middle, and work on the muscles and motor control so that the passive restraints can be augmented by increased muscle activity to help with stability, or increased motor patterns that help you to perform at high levels of activity. Okay, so when you look at ACL injuries, they can be traumatic, contact, and non-contact. We'll talk a little bit about that. So you can see that these really are the anchors, right? They provide a lot of stability and a lot of proprioceptive input into the knee joint. So you have your partial tears and your complete tears. What you see here in this image is this intact anterior cruciate ligament. And then here is the disrupted anterior cruciate ligament. Remember also that for a lot of these ligamentous injuries, that the joint, right, has to have moved significantly out of neutral, whether it was through contact or non-contact, which potentially could put bony surfaces in contact with one another. So it is very likely also that there might be bony contusion or bruising, which could be a part of their pain experience. Okay, so we'll go to PhysioU and take a quick look. Let's go back to, here is Clinical Pattern Recognition app. We can go back to the knee. And again, pain patterns are not that predictive, but a lot of patients do complain of anterior knee pain. So here is, okay, so we can go look at pain patterns. Let's go for medial knee pain, and here as one of the potential options is anterior cruciate ligament. So again, this data is inside the table that is in your slides, but they come from the PhysioU app, and I want to just point out a few things here. Now, female athletes with ACL reconstruction that return to sport are 4.5 times more likely than males to re-injure, okay, within the first 2 years. Young men had the highest incident rate at 241 per 100,000 person years, okay. Approximately 70% of all ACL injuries are non-contact, right? Second ACL injury rates are 15%, and patients younger than 25 years had a second ACL injury rate of 21%, okay? Girls in sports with the highest injury rate in order is soccer, basketball, and lacrosse, the highest injury rate, and then boys have the highest injury rate in order: football, lacrosse, and soccer. Now, ACL injuries are very common also in younger female athletes, okay? So again, all the data is here, your references. Now let's take a look. Let's take a look at the signs and symptoms. Okay, so we'll go back to anterior cruciate ligament. We'll look at clinical findings. And let's take a look here.
Knee stability and movement coordination impairments, or anterior cruciate ligament sprain or tear. The patient often reports knee pain that may be difficult to localize. There's often a history of trauma or hyperextension and immediate swelling of the knee. During functional movements, the patient may report a sense of instability and buckling.
So a few key things to note. Usually with a ACL type injury, there is immediate and significant swelling that occurs, okay, as compared to delayed swelling. And the sense of instability is different, right, from the clicking and locking that comes with a meniscal injury, okay? The location of pain, because the ligament is deep within the knee joint, is difficult to localize. So when you look at the history and reported findings, and remember this is in your tables for quick reference, you can see that many of the causes in terms of the non-contact involve cutting, pivoting, sudden stops, or landing from a jump. Okay? Mechanisms of injury consisting of deceleration or acceleration motions and can also relate to non-contact valgus load at or near full knee extension. Okay? The patient may hear or feel a pop at the time of injury. There is usually immediate effusion, so the knee swells up significantly right away, and feeling of instability or giving way with weight bearing. When it comes to reported findings, the patient may talk about increased instability, especially with changes of direction, difficulty weight bearing, especially in the early phase where there's pain and edema. And remember, I talked about bony bruises potentially. And here under ACL tear related to trauma or strain, the patient again may mention an audible snap or pop, followed by immediate large effusion or heme arthrosis. In terms of ACL insufficiency, they may have episodic giving way, so some instability, and some effusion and pain with specific activities. Pain with specific, usually pivoting activities, okay? When you think about the examination finding, there's a few key tests that we'll probably do. Here, the positive Lachman's test, potentially a pivot shift test, but usually the pivot shift test is done under anesthesia, so you will be unlikely to do this on the patient. And there's a number of functional tests that I think are really useful to think about. Now, you have to decide, is it safe to do those functional tests for the patient at the time of your examination? So you have 6 meter single limb timed hop test, because it really allows you to assess that instability, right? You'll also look at some key muscle tests like the maximal voluntary isometric quadriceps strength, and listening for a history of giving way. So episodes with 2 or more activities of daily living. So a key question when it comes to ligamentous instability is, tell me about the things you normally do for sport or for work, and how does this knee problem affect you? If they're like, I don't feel safe standing on my knee or walking on uneven surfaces, it gives you another clue. And just remember that it is valuable to do tests like single leg hop, like a bunch of the noise hop tests eventually, as a way to decide, is this patient appropriate for rehab? Is this patient a coper? Or is this patient more likely to benefit from surgery? These things you and your instructors will discuss further. Okay, so that is the mechanism of injury, as well as the common signs and symptoms and common examination findings. So if we look back to the PowerPoint for a second, okay, all of that is what we just talked about in summary. And what I want you to note is, because this is a motor coordination, right? Stability and motor coordination impairment. The treatment-based classification that it would fit is, hey, I'm having a hard time staying near middle. My anchors are injured. So I need help with stability, stabilize. Remember, I said the rehab concept for management of this problem is typically related to, 1, reduce pain and inflammation and protect those tissues, stabilize it. So they may need temporarily a brace to keep them near middle while the tissues are calming down and to prevent re-injury. Eventually, though, as the pain and swelling are going down, you have to start thinking back up the pyramid. What do I need to do next? Well, lots of times with the pain and swelling, they may not have been able to fully extend or flex their knee. They may have mobility deficits. So that's why you see I've put mobilize here. I need to restore range of motion, move them up the pyramid, eventually improve the quadriceps strength, and help them work on balance and proprioception and high-level sporting activity. There are many decisions along the way that need to be made about whether they are copers or non-copers. But your job, if you're treating them in a non-operative, so conservative care methodology, is really to manage the pain and swelling, eventually restore the mobility and strength, and then work on proprioception, balance, functional movements, and make sure that they don't have any bad movement faults. And so we'll look at that in the app, okay? So if we go back to the app here, and I look at ACL under physical exam, you can see that the key examination findings, we always put this pain-limited knee management. If they're swollen, painful, and you don't know whether you should perform all of these tests, it is totally appropriate for you to help manage that pain and inflammation. It's at the base of that pyramid, remember? So, and I'm going to pull that pyramid up here again. Here is the pyramid. So remember, it's totally fine to put a patient in a pain control category. Now, as you move forward, I'm the mobility expert. I have to know whether they have full range or not, right? So here is my standard exam, nothing special there. And here is my ACL assessment. Okay, so anterior drawer test, Lockman's test. So when you look at the numbers, okay, so here is an anterior drawer test. You're going to pull the tibia in the anterior direction. If you look at the sensitivity and specificity, they're pretty good. The positive likelihood ratio is 10.2. Okay? So if you want to get an idea of how that affects your decision, we can look back down here and note that a positive likelihood ratio of 10 or greater, there's a large increase in probability that a disease is present. Okay? So imagine that the patient comes into you and says, hey, I was running, cutting, and my knee buckled. It swelled up right away, and now I'm having problems walking on uneven surfaces. They give you all these clues. So here's your pretest probability right here on this side. So you're like, based on all of those injury mechanisms and all of your signs and symptoms, I have a pretty strong feeling, let's say 60%, 70% feeling that you are you have an ACL tear, but I'm going to apply the Lockman's test. So we start, if you put a dot here, and you apply a test that has a positive likelihood ratio of 10.2, if you draw a line from 70 through 10, you're going to end up somewhere up here, 90+%, let's say. And so that one test, along with your pretest probability, your high pretest probability, allows you to have a large level of confidence that what you're looking at is a significant ACL injury. Okay, so that's how you use the positive likelihood ratios for this test, right? So there's your 10.2. Okay, so there's your testing. If we go back to, let me just double check in the pain limited knee management. Yep, same idea. Unload it, ease the knee, put them in the open pack position. And again, I would invite you to consider the differential diagnosis, clear out other structures that may refer pain to the area or might have been injured during that trauma, and screen out other post-traumatic structures like Mcl, Lcl, meniscal, right? Because of the terrible triad, many of these injuries occur together. So you have to kind of figure out what's going on. All right, and then when you look at your movement faults, you'll see that there's a couple of key movement faults here. Excessive quad dominance, knee hyperextension. Remember we talked about hyperextension movement or trauma could be related to the ACL injury, as well as excessive femoral internal rotation. So you guys can explore these movement faults. How do I look at for them? How do I correct them? How do I train a patient to avoid these movements? And then your associated impairments. How do I assess my edema, your modified stroke test, your bulge sign, right? So these are all things you're going to learn in lab. And then here you can see lower quarter muscle weakness. You're going to do some muscle testing with the isokinetics or the hand dynamometer. Here's impaired balance and proprioception. Some tests that you can use, start excursion balance test or a hop testing. Okay, so here's your noise hop test. Now, remember, you have to use your clinical reasoning. Is that something appropriate for you to do on your day one eval when they're still inflamed and painful? No, you don't need to do that. But over time, this testing is going to be very useful for you to determine whether they are a rehab candidate or a surgical candidate. All right, so how do I manage these patients? If I move back to ACL, interventions, make sure you watch your clinical reasoning video in your interventions. But remember, initially, I may have to manage them by providing some stability, right? Stabilized treatment category. Cryotherapy to prevent or reduce swelling. Taping to reduce the knee hyperextension if that's what you see in the patient. And then NMES. Okay, so the guidelines suggest B moderate evidence for NMES. So that's why your modalities, it's important. Okay? And if you look at what do I do after I reduce the swelling and I've protected the joint? Well, I need to restore mobility. So nothing new here. You're just marching your way up the pyramid. Right? Get rid of pain and inflammation, protect the joint near neutral, restore mobility and muscle length, work on muscle power, now work on balance and gait and functional movements of squat, lunge, cut, hopping, right? You're always working your way up the pyramid. All right, moving on to, you can see there's improving patellar mobility, restoring knee flexion mobility, all of these techniques that you guys are going to learn in class. MWMs with the belts, soft tissue mobilization, contract, relax to restore mobility deficits of the tissues. Okay. Let's look at the therapeutic exercises. Again, if you're restoring mobility, you have a bunch of matching therapeutic exercises to restore mobility, right? So whatever you do in the clinic, you should be matching with some therapeutic exercise that helps to restore or manage that key impairment. Then if you move into motor coordination, you'll see that we want to train the patient to address the movement faults that may have predisposed them to injury. And of course, there's quadricep strengthening, hamstring strengthening, balance and proprioceptive training, single limb stance skaters, perturbation training on different surfaces, star excursion balance test, which is an assessment as well as a great exercise. So you can see you're marching your way up the pyramid with your interventions. Restore mobility, restore strength, now work on balance and gait, and then higher level functional activities. Okay, so just remember for each condition, under interventions, you have patient education. You should always know what you need to tell the patient. And you have a bunch of cool articles here from JSPT. When should an athlete return to sport after ACL injury? When to resume full activity, right? So you can always share that education page with the patient. So this becomes our students and our clinicians will send a patient education piece after every eval. They will get a patient education piece. Now, one other thing that I want to show you, if you go back to the PhysioU apps, under patient education, we have a special directly written for patients piece of education. So here's ACL surgery, getting back to your sport. So you'll see one of our clinical specialists will talk to the patient and tell them that they're going to be okay.
250,000. That's the number of ACL injuries that occur every year in the United States. Most of these injuries happen in young athletes in sports that involve jumping, pivoting, or hard cutting. 100,000 is the number of ACL reconstruction surgeries that occur every year in the U.S. Just about every athlete wants to know one thing after their ACL surgery. When can I get back to my sport? To answer this, we'll look at how much time you should spend in physical therapy rehabilitating, how many months after surgery have been proven for the best outcomes, and physical requirements to return to your sport. For more information, please read below.
So remember, there's this written piece for you to share with your patients. And it also includes some basic exercises eventually that they'll have to learn to do. Okay? So you can share this page with your patients. And boom, it's gone. Patient has now access to this article. All right, so remember, you can now add these patient education pieces into your care. Okay, so that is ACL injury. Let me talk briefly about PCL injury. So if we go back to the PowerPoint, what I want you to see here is the PCL injury is opposite to the ACL injury. The tibia now moves too far posteriorly. Here you see the normal PCL. Here you see the disrupted PCL. And we have generally looked at, I think if we go to PhysioU, let's just take a look at, we don't have to go through the entire thing because it's, besides the testing, the concept is almost essentially the same as ACL. Okay, so if I go to all diagnosis, I look at posterior cruciate ligament tears. If you look at the prevalence, most common causes are motor vehicle accidents and athletics. 2% of American high school knee injuries, more common in males. Okay, a majority of the full tears are associated with multi-ligament injuries. So here's 0.65% to 44% of all ligamentous knee injuries. So if I go back to looking at the clinical findings, let's just take a quick look.
Knee stability and movement coordination impairments, or posterior cruciate ligament sprain or tear. The patient often reports knee pain that may be difficult to localize. There is often a history of trauma with a tibia forced posteriorly and immediate swelling of the knee. During functional movements, the patient may report a sense of instability and buckling.
Okay, so you can see that the mechanism of injury is a little bit different. This time the tibia is shoved posteriorly. And if we scroll down and look at the history a little bit, again, the sports are very similar. Pivoting, sudden stops, landing from a jump. But in the case of traumatic injury here, you see a dashboard in the car, right? The tibia is jammed into the dashboard in the car accident. There's an anterior tibial blow, right? Shoving the tibia posteriorly, a fall on a flexed knee, or a sudden violent hyperextension of the knee joint. And because it's a cruciate ligament, it's deep within the joint, the effusion is immediate. Again, it's immediate, significant effusion. When it comes to looking at the reported findings, again, you see, hey, this is a movement coordination impairment, a stability issue. The patient complains of instability, difficulty with direction changes, potentially difficulty with weight bearing. So localized posterior knee pain with kneeling or decelerating. Okay, so typically we do the posterior drawer test at 90 degrees or the positive posterior sag sign. And eventually, just like the ACL, we would do some types of noise hop tests, the hop testing, because the concept of management and examination is very similar. Okay, so all I'm going to do here is take you to the physical exam just to highlight that the test that we're going to do here, very standard knee range of motion assessment, but here's my Pcl assessment where I'm looking for a posterior drawer. This time I'm seeing how much displacement in the posterior direction that the tibia will go, and also looking at a posterior sag sign. Remember, if the restraint for tibial posterior glide is now missing, you may see that the tibia sags with gravity. And the tricky part here is because it is sagging posteriorly, sometimes when you do an anterior drawer test to rule out ACL involvement, you might feel excessive excursion. You might say, ooh, that feels like a positive anterior drawer test. But in fact, the ACL is intact. It's just that you're starting from a posterior position, a posterior sagged position. And so it feels like there's a large excursion when in reality, the ACL is intact. It's the Pcl that's torn. Okay, so some of your special tests here for you to look at. Okay? All right. Management strategies are essentially the same. You can explore that on your own. I would just say that we are marching our way up the pyramid. First, manage pain and inflammation and provide stability, because that's what we do to ligamentous injuries. Then, when the pain and inflammation are gone, I need to restore mobility, restore muscle strength, work on balance and gait, and work on functional movements. It's exactly the same, okay, as an ACL injury. But the difference is that when you are trying to rule in or rule out the condition, you are using different special tests. Okay, but the rehab concept of management is pretty much the same. So when you explore the interventions, you're going to see that it's very much the same concept, right? First, reduce pain and swelling, brace it, give that tissue some time to rest and protect it. Then restore mobility, manual therapy, restore mobility. Give them exercises that match, that help to restore the mobility. And then eventually, I need to work on motor coordination, change their movement faults, work on strengthening their quads, balance and proprioception training, hop testing and functional training. Eventually, you're just marching your way up the pyramid. Okay, so that is posterior cruciate ligament. Let's go back to the pain patterns, and we are going to, so that was what you saw here for your ligamentous injuries, and our last category is Mcl and Lcl. So I've lumped those two together because in reality, the management strategy is almost exactly the same, whether it's medial or lateral collateral ligament injury. Okay? Because in the end, it's a stability and movement coordination, knee pain, knee stability and movement coordination problem. So what I want you to think about is, how do I injure an MCL? Well, usually a valgus stress to the knee stresses the MCL and creates either minor tears, right, or complete tears. And if you look at here's the LCL, because here's the fibula, this is going to typically be injured by a varus stress. So the varus stress stresses the LCL and leads to your ligamentous injury. Okay? So if we go into PhysioU, go back to knee, go to all diagnosis, let's say, or if we go back to the pain pattern, actually we could play the pain pattern, clinical pattern recognition. Here I'm looking for the pain pattern, and patients like, ooh, I have medial knee pain. Here is one of my hypotheses, medial collateral ligament sprain. Okay, so if we look at the prevalence, 7.9% of all athletic injuries. Most common multi-ligament knee injuries involve both MCL and ACL. It's part of the terrible triad. You can see that there is some prevalence numbers for military cadets, some prevalence numbers for collegiate athletes. Okay. Now, if I move into the clinical findings, let's take a look at how these patients present.
Knee stability and movement coordination impairments, or medial collateral ligament sprain. The patient often complains of medial knee pain near the joint line and a history of trauma involving a valgus stress to the knee. Uncoordinated functional movements like squatting, here you note excessive adduction internal rotation of the femur, may produce microstresses to the tissues. Movements that may strain the affected ligament, like bending and twisting, may also reproduce the pain.
Okay, so those are your findings. If you look at the history, what does the patient tell you? Well, I don't usually injure ligaments without trauma, okay? It could be non-contact or it could be contact, but usually there is some direct trauma to the lateral aspect of the knee joint. And it could also include a rotational component. Repetitive valgus stress applied to the knee joint during daily activities or sports, whether it is one-time high-force trauma or multiple micro movements that are stressing the ligament, could be related to the injury mechanism. So when you talk about the examination findings, primarily you're looking for laxity with valgus stress test or pain reproduction. You can see that the criteria for a positive test are both pain and laxity. Whenever we look at tendons or ligaments, we also palpate. So tenderness over the MCL, seeing if it reproduces the patient's familiar pain. And then you should also look for impairment measures and look for the asymmetries, right? Whenever we do a valgus stress test, we often will do the uninvolved side first to get a sense of what is the normal stability or laxity of the uninvolved compared to the involved. Just like all the other ligamentous conditions we talked about, when it is appropriate, it's valuable to look at functional tests that allow you to really see whether the instability, the poor coordination, whether the impairment or tear causes some true functional limitations, and to be able to detect side-to-side asymmetries. Okay, so in the end, it's useful to use these similar tests, which is nice because we've talked about ACL, PCL, MCL. You can imagine LCL will be exactly the same as what we think about here because they're all parts of the passive restraints of the knee. Okay, so if we go back to looking at, let's see, if we go back to the physical exam, nothing new here. We've talked, let's look at the key findings. When they're really painful, you know what to do. We are specialists at knee mobility, right? So it's standard that we need to check this. And here's your MCL assessment where you can look at the valgus stress test. You can look at the medial collateral ligament palpation test. There's other tests that you can use, but this is essentially the gold standard here. All right, so again, you can watch the technique, note the sensitivity and specificity. Okay, and if I go back to talking about the differential diagnosis, it's very similar, right? Clear other potential structures that might have been involved and rule out other post-traumatic structures that we think may be involved. So you've got ACL, LCL, meniscal, okay, and patella. Intervention-wise, I just want to mention that the interventions are going to be very similar to all the other ligament problems. Manage the pain and swelling, provide stability, early activation of the quads, taping that might help relieve stress off of the structure. Okay, so it's supporting the medial knee here. And then when you look at the manual therapy, you're just moving your way up the pyramid. So we are here taking care of protecting the joint, reducing pain and inflammation, keeping the joint near neutral with your bracing and taping, and then restoring mobility, right? So here we are restoring mobility with all the manual therapy techniques you guys are going to learn. What you're seeing is a repetitiveness, which is okay. It's nice that there isn't some special recipe for every single different condition. If a condition is generally related to stability and ligamentous, right, poor movement coordination or movement coordination impairments, right, there is ligamentous instability, then the general rehab concept is the same. right? We're going to spend a lot of time after we restore the mobility with therapeutic exercises that also restore the mobility, and movement coordination exercises that manage common impairments of glute strength, quad strength, functional movements that might contribute to the problem, like excessive foot pronation. This talks about the regional interdependence related to lower quarter injury, right? So learning how to control midfoot pronation, learning how to control or correct excessive femoral internal rotation adduction. Okay, and then moving on into balance and proprioception training, it all begins to look alike because you're moving up the pyramid. You can imagine we would do this same kind of stuff with someone with an ankle sprain, this same kind of stuff with someone with a labral tear. When they get to that point in the pyramid, all of it begins to look the same. Okay? So, and then don't forget, you have your patient education, your JOSPT patient perspectives, and things that you would be expected to say. We wrote this in layman's terms so that you can answer the key questions that patients want to know about. Okay? So that is medial collateral ligament sprain. If I talk briefly about LCL, in fact, let's go back to the PowerPoint just for a second so I can reorient you. Here in the table, what I've done is I've put LCL here and MCL here. But remember, a lot of this treatment categories, stabilize, pain control, exercise, a lot of these relate to both. In fact, they're very similar to the ACL group as well, or PCL. So if I go back to here, go back to the knee, and we're just going to watch a couple of quick things and then we'll be done. Okay, so here I'm going to go lateral collateral ligament sprain. Here's the prevalence data. 4% of all knee ligament injuries, highest risk associated with tennis and gymnastics. And if you go back here, you can see in the clinical findings, the patient has lateral knee pain, right? Because this is the ligament that's sprained.
Knee stability and movement coordination impairments, or lateral collateral ligament sprain or tear. The patient often complains of lateral knee pain near the joint line, a history of trauma involving a varus stress to the knee, uncoordinated functional movements like squatting or cutting may reproduce the patient's pain.
Okay, so when you look at their findings, it's going to be very similar to MCL if you look down here, except that instead of a valgus stress, a varus stress is applied to the knee, whether it is from trauma or a fall, right? Here's direct trauma to the medial knee aspect of the knee joint, right? Medial knee aspect, creating a valgus stress, a varus stress, which is injuring the lateral collateral ligament. And the patient may demonstrate localized swelling over the LCL. They may complain of instability and pain with weight bearing and changes of direction. There may be some pain, difficulty with weight bearing, right? When we go through the examination, it's primarily varus stress test at 0 and 30 degrees. Why do we do it at 0 and 30? Well, because at 0, the knee is in its closed pack position. It's really hard to test ligaments there. Okay, so when you put it closer to an open pack position, now you can really test ligamentous stability. Okay, so yes, they do recommend doing it at 0 and 30, but really at the 30 degree mark, you really get a better chance of testing that ligament without the joint being in its closed pack full extension position. And just like with any other ligament problem, we stress it, we palpate it, and then we measure impairments, right? Stability and laxity, strength, swelling, range of motion, coordination. And again, you see the mention here of using these hop tests when it is appropriate. Okay, so I think the only thing I'm going to show here that's different is when you go into the condition and you look at the physical exam, you'll see that the examination is very similar. I need to look at mobility. I can look at strength if I need to. That's part of my associated impairments. But here's my LCL assessment, a varus stress test, right? The patient, this is the medial knee here, and the therapist is applying a varus stress to stress that lateral ligament. And then here's the palpation of the ligament. And in the physical exam, the associated impairments, glute strength, quad strength, right? Here's your quad strength with dynamometer, looking at hop testing. So all of these things are all the same because a ligament is a stabilizer of the knee. And so we look at activities that stress the stability system. Okay, so your interventions are going to be exactly the same, essentially, in terms of stabilizing the tissue. We look again at the interventions here. Watch your clinical reasoning video, but cool it down, reduce the pain, stabilize the joint near neutral, early activation of the muscles, right, that help to provide stability. And then restoring range of motion, boom, and restoring mobility with exercises, strength, balance and proprioception, high level function. You're moving your way up the pyramid. Okay, so you guys all have your PhysioU apps. I hope that's useful for you in understanding these main conditions, the meniscal injuries as well as the ligamentous injuries. Meniscal injuries count as mobility deficits. These ligamentous injuries, they tend to count as, if you look here, here's my ligament injuries, knee stability and movement coordination impairments, right? Here are my ligament injuries. They're all from the same category because the impairments are generally the same, which is why you saw a pattern of the management being very similar. It's just minor changes in the testing. And then here is your medial or lateral meniscal tear, knee pain with mobility deficits. All right, guys. So I hope that is useful for you. Feel free to email me if you ever have questions. Granted, you have an amazing group of professors that you guys can reach out to, but I hope that's useful for you and that you get a good glimpse into the app and how it helps you to develop the clinical patterns. So, all right, hope you guys are doing well. And thanks again, Dr. Minkin, for the opportunity to share with you and help you learn about ligamentous and meniscal injuries of the knee. All right, take care, everybody.